Good afternoon, everyone. If someone could give me a sign, maybe Loretta, you can let me know if you can hear me. I am very pleased to welcome you to Canadian Public Health Week's second webinar of the week. And we are, this is the impact of COVID-19 on public health. And we have both OPHA and OPHA joining us today, and it's about comparing experiences and sharing recommendations for the future. My name is John Atkinson, and I'm the Executive Director of the Ontario Public Health Association, OPHA. I am joining you today from Hamilton, Ontario, and the city of Hamilton is situated upon the traditional territories of the Erie, Neutral, Huron-Wendat, Haudenosaunee, and Mississaugas. The land is covered by the Dish with One Spoon Wampum Belt Covenant, which was an agreement between the Haudenosaunee and the Anishinaabe to share and care the resources around the Great Lakes. On behalf of OPHA, we work and are committed to engaging and working with First Nation, Inuit, Métis communities in a spirit and a course of reconciliation moving forward. Over to you, Loretta.
Thank you for reading the land acknowledgement, and I'd like to welcome everyone on behalf of the Association of Local Public Health Agencies, better known as OPHA. My name is Loretta Ryan, and I am the Executive Director, and we're also pleased to be here today to help celebrate Canada's first Canadian Public Health Week.
So today's a very exciting agenda. Both OPHA and OPHA have either released or are on the doorstep of releasing two exciting reports. One called Public Health Resilience in Ontario, Clearing the Backlog, Resuming Routine Programs, and Maintaining Effective COVID-19 Response. They'll be talking about their findings, and OPHA will be sharing a report towards the end of April on a report called What We've Heard, COVID-19 Shaping Public Health in Ontario. And we have a very interactive session with the plan for today with polls and Q&As, so please jump in and have fun with the technology, and Casidhe will tell you how it actually works.
John. So today we're going to be using a platform called Mentimeter. So we ask that you have prepared either on your computer or on your mobile phone to go to menti.com. When prompted, you will be given a code to do an activity, an interactive activity on that platform. Each time that we give you a new code with a new slide, we ask that you either re-enter menti.com or press the button at the bottom of the screen that prompts you to join a new session. We also ask that if you have comments throughout the presentations, please feel free to use the chat box. And if you have questions for the presenters, to please use the Q&A function. If you ask questions in the chat box, there is a chance that we will not see that question. So we do ask that if it is a question that you'd like to ask, to please use the Q&A chat box at the bottom of your screen.
I now have the pleasure of introducing Dr. Charles Gardner, who is the chair of the Council of Ontario Medical Officers of Health, better known as COMO. He is the COMO representative for Central East region at OPHA and has been the medical officer of health for the Simcoe Muskoka Health District since 2005. This was after having served as the medical officer of health with Leeds, Grenville, and Lanark District Health Unit. Prior to that, he worked in general practice in Newfoundland, New Brunswick, and Zimbabwe. In the past, Dr. Gardner has been the chair of the Council of Ontario Medical Officers of Health before, so he's doing this again. He has been president of OPHA, and he has been president of the Ontario Council for Community Health Accreditation, a member of the Ontario Public Health Leadership Council, and co-chair of the Healthy Environments, both natural and built table, for the Ontario Public Health Sector Strategic Plan. Welcome, Dr. Gardner.
Thank you very much, Loretta, and it's great to make acquaintance with all of you. I'm just going to take a moment to pull up my presentation. And at this point, people should be seeing it. So there are going to be a couple of polls midway through this. Loretta is going to be helping me with that. This is a presentation that came out of an initiative to document what we've not been able to do through the pandemic, as well as the resources that we've had to put forward in response to the pandemic, health units in Ontario, so local public health in Ontario. So first off, I think it's really, really important to acknowledge that public health is very much the backbone of the response to the pandemic, that through our many actions across the country and certainly in Ontario, we've bent and flattened the curve repeatedly and helped to prevent illness and death. We've had to do so in a variety of ways, initially limited to public messaging and case and contact management, isolation, outbreak response, and then coming at our disposal was the enforcement and education about public health measures and restrictions put in place by the province. In some instances, our own letters of instruction or orders to help protect the public, and then the beginning of immunization. And through all of this, we've done what we can to keep up our other programs and services, but to a very, very large degree, they've been put on hold and very tragically have had their own impacts being put on hold. And if it weren't for all that we did, no doubt there would have been a lot more in the way of preventable mortality. Initially in the pandemic, we were seeing a 2% case fatality rate. That really would have resulted in 20 or more fold mortality compared with what we've seen. So in our response, we've been busy. So what's been the impact of the pandemic response on our broader public health program delivery is very much what my presentation is about today, an attempt to gauge that. How do we maintain our resilience in the face of the ongoing pandemic? Because tragically, it continues despite all that we would wish, and perhaps despite the public mood right now, the pandemic does continue. And how do we also return to our broader mandate of program delivery in the face of a continuing pandemic? So key questions that we've sought to answer. We did a survey, the Council of Medical Officers of Health in Ontario did a survey of our membership of health units across Ontario in order to gauge what programs and activities have been put on hold, how much of our resources have been redirected to the pandemic, where we'd experienced some augmentation or efficiencies or enhanced capacity, and what we would prioritize to return to begin to get back online, what we've had to put on hold. So we provided our findings to the Chief Medical Officer of Health of Ontario at the beginning of October. And that never was made public, but what we did make public was a version of our findings under the banner of OPHA, an OPHA report that was issued in January and is on the OPHA website for all to see. So certainly would encourage people to have a look at that product. We've had enhancements of activity in response to the pandemic, and these have included data analysis, management, reporting, visualization, and surveillance, and having a look at the websites of health units across the province. You will see evidence of this, a tremendous amount of information and data about the pandemic and various metrics of the response to the pandemic, the impact of the pandemic. There's been a tremendous amount of communication to the public and to partners with media piece updates and communications to special and particular audiences, whether it would be to healthcare, municipalities, businesses, or other. We've engaged with and collaborated with sectors of the community whether it would be those who provide vaccination with us, whether it would be other healthcare providers for other reasons, whether it would be with municipalities about their own contributions to the pandemic, or businesses or other stakeholders, and have participated in education, had to adapt to very much online as a means of doing so, and have done so with schools and parents and with primary care providers, and also the general public and the business community. Usually in a two-way format. Health equity has been very much part of the response, and data that we followed has demonstrated where there have been inequities, where there have been communities and subpopulations that have been much more heavily hit by the pandemic, or have lagged in their ability to have the same kind of vaccination coverage. And we've sought to focus and direct our efforts to address those to the best of our ability and work with partners to those ends. And of course, we've continued in emergency management as an approach to the whole thing, including education and enforcement of legislation. In order to achieve all of that, we've had to redirect our resources, and most of what we normally do has been put on hold. And so in 2020, 74% on average among health units of our resources were redirected to the pandemic. And up to August of 2021, when we took our survey, it was up to 78%. And you see from these graphs the distribution and how it shifted all the more to the right, all the more to a greater degree of redeployment in 2021. In Ontario, we do have Ontario Public Health Standards that specify in a fair degree of detail the programs and services to be provided by local public health units. And there are foundational standards as well as program standards. And what we found from our survey was, as I'd indicated, the great majority of what we've had to do normally had to be put on hold. And we do see that in the overall foundational standards about population health assessment, health equity, and effective public health practice. We certainly were busy in those areas, but directed to the pandemic overwhelmingly. And so the full coverage of those programs was largely put on hold. And when we look at our program standards, we see that there's a fair range of difference in the degree to which this kind of impact was experienced. So emergency management was at the top end, 56% of the indicators of programs were met. And at the bottom end was chronic disease prevention and wellness, food safety more in the middle at 41%, healthy environments at the low end at 37%, healthy growth and development at 28%. If we look at other programs, although we were carrying out the largest immunization campaign in history, we've had to put on hold other routine immunizations, including immunizations provided in schools in grade 7, where we now have a gap of perhaps 300,000 students, or 80% of the vaccination that was to be provided that's not been provided, for which we need to catch up now, at the same time that we find ourselves with yet another round of booster immunizations for COVID-19. Infectious disease response at the higher end of 58%, but very much focused on COVID. Water response, the highest degree of compliance at 63%. School health at the lowest end at 13%. And for sure, we did a tremendous amount of work in schools, but it was overwhelmingly focused on COVID and keeping schools safe and open, even having more additional hires to manage that. But with schools closed for much of the year, very difficult to do other programming. And substance use quite low at 21%, noting that opioids has actually had a substantial increase in mortality, some 79% increase in mortality compared with pre-pandemic. And also this is the area in which we normally are addressing issues such as tobacco, the single most important preventable cause of death. So You can see and I think imagine the broader impacts related to this degree of non-compliance or inability to be able to keep up our broad programming. So at this point, we're going to stop for a poll because I'm going to be asking yourselves, what public health programs do you believe need to be restored earliest?
Okay, so hopefully everyone can see my screen at this point. We are going to ask that you go to menti.com and use the code 60569646 and enter in your answer. Okay, thank you for all those participating. We can see a lot of immunizations and harm reduction, screenings, but a lot of variety in those answers. Dr. Gardner, I'll pass it back to you to continue your presentation.
Okay, thank you very much, Casidhe. So I will share again my screen. Okay, and people should be seeing that again. You know, obviously it's a very difficult question to answer. And so for us, we felt that although it's desirable to get everything up and running again when you are under limited you know, constraints with resources and still having to respond to the pandemic, you're left with the difficult task as to what you would do first. So from our survey of our membership, we found the following rose to the top: mental health promotion, substance use, including opioids, child immunization catch-up, food safety inspections, and oral health. And one thing I would say about oral health is that, once again, there were some 300,000 children who did not get oral health screening in early school because we weren't able to keep that up. And that would be an example of the gap in that particular program. And this does not mean that we would not advocate making gains in all of the other programs, as you can do so. It simply was the outcome of our survey about where you would begin. Another question for yourselves: what enablers do you believe are most needed at this time for the ongoing resilience of public health programs in your jurisdiction? And there's a request for the, yeah, okay, Casidhe, I see that you're chatting with everybody.
No worries. Yeah, so we do ask that you go back to menti.com. It should be the same code as last time, which is 60569646. I'll put that in the chat box. You should also be seeing it at the top of the screen as well. Thank you to those that are able to get their answers in. And if you are having trouble, feel free to put comments in the chat box as well. But we're seeing lots of funding, human resources, capacity. Thank you. Okay, Dr. Gardner, I'll give it back to you.
Very much. So I would say that what was shared among yourselves with us, I think aligned well with the priority areas that were identified in the COMO submission to the province and the OPHA report released to the public. They come into three broad categories. So one is provincial support for the ongoing pandemic itself. So maintaining a kind of investment in science structures and resources to support a multi-sector effort required to effectively manage the pandemic. And this really comes down to the province and provincial agencies continue with the leadership, with overall direction for the pandemic, with the provision of guidance documents, with directives as required, in order to enable us to continue to rally behind that as local public health units and carry out what's needed on a local level. I think I'll just go on to the next response, and that is that there'd be provincial support to local public health to protect and promote health of Ontarians through financial investments in the health units that are clearly communicated and committed early in the fiscal year. And so this would be funding for the ongoing response to the pandemic, funding for the recovery of programs and services, noting the kind of priority areas that we had identified, and support for base funding going forward in the future, noting that in a number of past years, our base funding has been frozen. And so there was some degree of reduced capacity going into the pandemic. So very important that we have that kind of support going forward. And then finally, that the province should support evaluation and renewal. So continue to work with health units and stakeholders, public health stakeholders, such as Public Health Ontario provincially, the Office of the Chief Medical Officer of Health and local public health agencies to develop a vision for a stronger, responsive public health sector with the capacity to address population health needs through various partnerships into the future. So taking the time at this point in time and in the near future to evaluate all aspects of the pandemic response for lessons learned and for application to the strengthening of the public health system overall, provincially and locally, and providing support to local public health to be able to participate fully in that evaluation. So one other thing I would note is there were a lot of comments with regards to the restoration of staff as individuals. And so I certainly would concur with that as well. That's been a priority, I think, across the field and in my health unit as well, although a challenge as, in fact, we're starting to see yet another wave of COVID-19 happening. So uses for this report, there was the original COMO, Council of MOH's report submitted to the Chief MOH last October, and then the alpha version for the public released in January and circulated to partner agencies. We cited its contents in a submission and presentation on the Ontario pre-budget consultation. And we have just released an election primer communicating to candidates during the provincial and because in June we have a provincial election, and then later in October, municipal elections, the contents of a report and the overall importance of public health. So you can have a look at our election primer on the Alpha website. And it does provide a key ask about recognizing the importance of public health in the pandemic response and the importance of the resilience and support for public health in our recovery. It identifies our roles and contributions to the pandemic response. It identifies the importance of investing in public health, the return on investment, and also the program impacts the curtailment of what we've had to do in order to respond to the pandemic. So at this point, I'd be happy to take any questions. I believe that Loretta would be helping me with this at this point.
I am, Chuck. I just had to unmute. I apologize.
Yeah, no problem. Let me take down my presentation.
Here's a question here. We have from an anonymous person. Shouldn't ecological environmental programs be included as public health priorities?
Well, I've had a long-standing direct involvement professionally in the built environment and health, as well as climate change. So certainly that would speak to my desires. But what I've spoken to today is what has come out of our survey, work with the field. So I believe that in due course, one would need to put resources back into responding to the ecological determinants of health as well. It's just that it didn't figure prominently as the earliest of activities that we would want to engage in our recovery.
Thank you. Does anyone else have any other questions? We have a couple of minutes here. Oh, here's another one from Jane. Are VBD managers planning to go into high schools to catch kids up for immunization in the fall?
So I know that in Simcoe, Muskoka, we are planning on doing that. I believe that the approach to that is going to vary among health units, some preferring to use a version of their large-scale community immunization clinics as perhaps what they would see as a more efficient way of doing it. But for ourselves in Simcoe, Muskoka, we are actually planning on going into schools as a way of outreach and improving access to immunization.
Thank you. And we have another question from Amy. Have green solutions been integrated into any of the next steps?
I think that would be related perhaps to the very first question about the importance of addressing ecological determinants of health. I didn't see this as a theme that came out of our survey work, so I cannot claim that was something that was strong in the findings. But speaking personally, I believe that this, addressing ecological determinants of health is important, and leading the way through our own practices is important as well. We've gained the capacity to do things remotely with less travel as perhaps a spin-off from the response to the pandemic. To me, that is something that we need to look at as one example of reducing our footprint in the work that we do.
Thank you. And we have one last question from Sarah. How is your health unit prioritizing programming as staff come back from redeployment?
We have done our own internal work, starting with the work from COMO and OPHA, and as a senior management team, looking at how we would adapt and identify for ourselves priorities, and incorporated that in our budget submission to the province for 2022 as one-time grants to augment and position ourselves in our recovery. There was something of a slowdown in the way of demand on the pandemic in the last month. And so we've started to redeploy people back to their work, and our senior management are well aware of the priority areas, but are also aware of other things that they would want to do within their departments beyond those priority areas. I think the new wave that we're now experiencing is making it challenging to continue that repatriation of staff back to their original work. And we're just going to have to, over time, as the pandemic waxes and wanes, look for the opportunities to build back those other programs as we can.
Well, thank you very much. That was a wonderful presentation, and I'd like to now turn the microphone over to OPHA. Thank you, Dr. Gardner.
Thank you, Loretta.
Thank you, Loretta, and thank you, Dr. Gardner. It's my pleasure to introduce my esteemed colleagues from the Ontario Public Health Association, who will be taking you through the next part of the presentation. First is Pegeen Walsh, who very recently retired as the Executive Director for the Ontario Public Health Association, paving the way for me to enter the organization and leaving me with big shoes to fill. We also have Sandy Maxwell, who's a senior policy and program strategist. She's also a registered dietitian and has worked in public health for many years. And we have Casidhe Gardner, who's not only our host extraordinaire, making all the technology work, but she's also a policy and program officer with us at OPHA. So over to the OPHA team.
Thanks, John. Last fall, as we looked at what was coming up on the horizon with the June 2nd provincial election, we wanted to be well placed to influence a new or returning government. So we reached out to over 400 frontline staff that were tackling COVID-19 to hear what they had to say about what was working well and should be built upon, where there were challenges that needed to be addressed, and what their suggestions were for the future. So we held some 16 consultations. We did a survey. We reached out to our members, our expert volunteer work groups, and our constituent societies that represent the different disciplines of public health. And what you'll hear from my colleagues is the feedback that we received during these sessions.
Hi, I'm Danielle, an epidemiologist at the Simcoe Muskoka District Health Unit, and I represent the Association of Public Health Epidemiologists in Ontario at the OPHA. Epidemiologists in public health units have experienced firsthand the insatiable appetite for data throughout the pandemic. Most public health units have small epi teams, so it has always been important for us to work with our colleagues across the province. Through this collaboration, we have created efficiencies and reduced duplication while maintaining local expertise, adjusting data analysis, and reporting to support our community's needs. The desire for comprehensive reporting on the pandemic's trajectory and public health response has highlighted the importance of data stewardship and data sharing, requiring both problem solving and collaboration to connect many and linked provincial data systems. This has also led to opportunities for new partnerships that we hope will grow post-pandemic. Epidemiologists and analysts represent a small but mighty public health workforce. In my mind, the pandemic has highlighted how nimble, flexible, and collaborative public health can be. With limited resources and small epi teams, public health units were able to scale up analysis and reporting to meet both internal and external demand while incorporating more interactive and open formats into our data visualization products.
So thank you to Danielle for sharing her experiences with what worked well in terms of public health response to the COVID-19 pandemic. She also shared how it will be important to build on these benefits. And that's one of our questions that we asked in our discussion sessions. And actually, Danielle hit on quite a few of the themes that we heard from our discussions and survey, including the agile, highly skilled, and responsive workforce. So public health personnel possess a range of specialized skills and competencies that have been critical in responding to the pandemic. The multidisciplinary approach to the COVID-19 response has helped to strengthen relationships among different groups of public health professionals. It facilitated learning between groups and individuals, which allowed for better service delivery. As Danielle shared, throughout the pandemic, there was a strong urgency to work together. New collaborations were established between paramedics, physicians' offices, public health, and hospitals. The pandemic highlighted the value in partnerships between hospitals and public health units, for example, with case investigation, patient care, and epidemiology. Strengthened connections were seen with various partners and agencies in the agri-food sector and enforcement partners. Relationships with schools and school boards were enhanced due to the provision of COVID-19 related services to schools. We heard there were elements of internal and external communications that worked well throughout the pandemic. Health units and community agencies did well communicating messages such as the importance of wearing masks to mitigate risk in the community. Regular meetings with provincial partners who were all involved and heavily invested, such as the Ontario School Health Managers Network, Ministry of Health, Ministry of Education, Public Health Ontario, were helpful in keeping health units well informed. There were efforts and creativity went into outreach in the community for vaccination, testing, and public health measures, including using buses and going to shelters or faith communities. There was agreement about the need to be creative to increase access for vulnerable populations in the future. The local context was also identified as being extremely critical in the pandemic response, from working with local advocacy groups to planning and informing interventions for priority populations in the community. Having a solid understanding of local communities allowed the development of effective targeted approaches, including reaching populations that had lower vaccination coverage. The application of equity-based approaches that respect diversity and inclusiveness was recognized as a positive element in the pandemic response. This included early recognition of racialized communities, deliberate and targeted outreach and advocacy for provincial collection of race-based data. Attention to the social determinants of health and upstream issues and solutions have increased. Recognizing the critical role played by the social determinants of health, public health has been using disaggregated data in meaningful ways, including going on site to do case investigation rather than over the phone. We have another question for you. If you could go to Menti and enter this code, 42951361. Question is, what do you think should be the next step in building a strong and resilient public health workforce? I know this is similar to our previous questions, but if you could just share what you think should be the next step. And again, focusing on the public health workforce. All right, thank you. I see lots more responses coming in, but seeing certainly a theme of investing in mental health supports for staff, recruitment and retention of a more diverse workforce, and yeah, investing in universal skill development has lots there as well, updating the public health mandate. So thank you for your responses.
Some of the biggest gaps that we saw emerge from the COVID-19 pandemic really had to do with a multitude of longstanding health and social inequities that were brought to light, particularly due to things like the Black Lives Matter protests and the discovery of residential school mass grave sites, which happened at the same time as the pandemic. Questions about who was able to protect themselves from COVID-19 when upstream barriers like paid sick leave or access to transportation were in the way really shed a light on the need for public health to address preventative measures in the upstream social determinants of health. Another gap that emerged was the need to collect sociodemographic and race-based data in order to allow us to accurately measure these inequities in the first place. And lastly, one of the most important pieces that emerged from the pandemic was the need to decolonize public health and to really broaden our understanding of what public health is in order to make our institutions safer and more trustworthy, particularly for Black and Indigenous communities.
One conversation that occurred throughout the pandemic was the way that it highlighted and exacerbated pre-existing inequities and areas for improvement in the public health system. As part of our discussion sessions, we asked participants to identify the problems and gaps that they felt emerged in the public health system during the COVID-19 pandemic response. Problems identified included those in the areas of communication, coordination, technology, relationships, and human resources. Participants indicated that the pace and frequency that new information and regulations were being shared by the province, usually to public health units at the same time as the general public, created a challenge for staff in regards to answering questions and sharing updates to the public and stakeholders. This often resulted in around-the-clock hours and duplications of efforts across organizations. Duplications of efforts was also a result of the variation of how public health units approach stakeholder engagement and their interpretation and execution of provincial updates. This also resulted in confusion by the public. In cases where units did collaborate in this process, it required a lot of time due to the volume and frequency of changes. There were also several issues related to the systems used for COVID-19 data collection, namely CCM and COVAX. At times, issues with these systems impacted the ability for health units to effectively follow up on contacts and track vaccinations. Further, the collection of social determinants of health data throughout the pandemic, especially in COVAX, resulted in few insights into how specific communities and marginalized groups were impacted by the pandemic. While relationships with businesses and the public were generally positive, participants felt that some relationships suffered and will need to be rebuilt. At times, health units got the brunt of negativity from operators and the public as they questioned the changing decisions and information. This is just one example of how public health staff were at the forefront of the pandemic response. They worked long hours in unpredictable situations and were impacted by the concerns of infection for themselves and their loved ones. The capacity to recruit, hire, and train new staff was limited, and there were negative impacts on current staff, limiting their capacity. Public health staff had to adjust to working from home, working in new roles, and finding work-life balance. As the pandemic continued with no clear end in sight, the mental health and well-being of many employees worsened to the point of some describing their situation as being burnt out. And finally, as shared in Alpha's presentation, we heard major concern around the public health programs and initiatives that were halted during the pandemic. Many respondents raised this issue of a shadow pandemic that has emerged due to the absence of programs and services focused on prevention and health promotion. Participants expressed distress and concern for those that have been left behind, already needing support prior to COVID-19, only to be made worse by the impact of the pandemic. Some fear that there may be reluctance from public health leaders to resume many of these upstream preventative focused activities in the future due to lack of resources. So we are going to go back to Mentimeter, and we're going to ask that you put in the new code. And we're going to ask that in 1 or 2 words, what areas of public health do you see as the biggest concern as we move forward? So to give some examples to get the ball rolling, you could put housing, alcohol, equity, vaccine hesitancy, opioids, but we do ask that you try to keep your answer to 1 to 2 words. I'll put the chat box to code again. So we are starting to see mental health kind of grow bigger in this word cloud. Equity is also a big one. Climate change. Oh, there's so many coming in. Health equity, vaccine hesitancy. That's really great. We'll make sure to capture this word cloud when we're at our presentation to see what it looks like in its final form.
To create a strong and resilient public health system in Ontario as we emerge and transition from pandemic to endemic, now is the time to look at lessons learned, and we can use the pandemic as a case study to determine which features of the public health system were effective and where were inequities present. What communities or populations were disproportionately affected and why? Looking at the pandemic purely from an infectious disease perspective would be a huge missed opportunity. An organization like the OPHA can offer so many perspectives and voices, including health promotion and intersectional approaches. Together, we have an opportunity to rebuild a better, stronger, and more resilient public health system in Ontario. But we need to capitalize on this moment before we slip comfortably back into the way we've done things in the past, because clearly some of those approaches favor certain populations and disadvantage others.
As Kevin has noted, this is a terrific time for reflection, and we did ask our participants, those 400 frontline staff, what they thought would be helpful to build a strong and resilient public health system and healthier communities in Ontario. And I wanted to highlight just 5 of the many recommendations that we heard. First of all, people emphasize that importance of fostering excellence in the public health workforce, whether that's investing in training or mechanisms that help sharing of best practices and allow for joint planning, and not only communication among health units, but also with the province. Another area that was highlighted had to do with tools. Frontline staff are saying, give us the best tools possible, be it technology, so we can make sure we can build on efficiencies. You heard our epidemiologists talk about the importance of having detailed data, especially disaggregate data. And importantly, looking at issues of governance and mandate to make sure that those that are sitting on boards of health across Ontario have that in-depth expertise of public health, and then to make sure those powers that exist within the medical officer of health and other parts of public health, that those are, that independence and powers are maintained and strengthened. As has been noted by many of you, our participants also talked about how critical funding is. And you may not be aware of it in Ontario, there was a shift in the funding formula so that municipalities were expected to take on more of that funding cost. And with the increasing pressures that municipalities are facing coming out of the pandemic, we are urging government to look at returning to a 75-25 split so that the province is carrying the lion's share of the cost of public health. And more importantly, that there be increased investments in Ontario's 30 public health agencies. Public Health Ontario also plays a critical role as that arm's length independent agency from government that can provide that technical and scientific support. So to make sure that it's not only well-resourced to handle issues like infectious diseases, but also handling health promotion and disease prevention. Our participants also gave us lots of terrific ideas about ways to strengthen community health. And as you heard earlier, that fear that somehow health promotion was going to be left behind, and how critical it is that we tackle those risk factors that we saw increase around chronic disease, and what that can mean for the pressures on our health system if we're not addressing issues of increased consumption of alcohol, disordered eating, inactivity, issues of substance misuse, the changes that are affecting maternal and child health. And as others have pointed out, how critical it is that we look at the climate change impacts on our health. We already heard from our colleagues at OPHA about that importance of catching up with that backlog. So again, to make sure there's that investment so that the return to mandated programs can be accelerated. So we would like to hear from you what changes you would like to see in the public health system to create healthier communities. And we have a code here, 9296-5600. It's at the top of your slide, but also in the chat box. So what changes would you like to see in public health system to create healthier communities? So again, if you could limit that to just a few words, that would be helpful. So we're seeing here more coordination by the Public Health Ontario, focus on environmental health, a more diverse workforce, consistent governance, retention of staff, issues of equity, integration, environmental health, more province-wide collaboration, independence from politics, equitable services, consistency across health units, early mental health resources, addiction and mental health, staff retention, I'm assuming integration of service, more interdisciplinary work, focus on those issues of coordination, collaboration, and communication, making sure there's more funding for health units, for Public Health Ontario, countering all the misinformation that we've seen during the pandemic, reducing duplication among our health units, making sure there's stability, and again, funding for staff retention, a focus on environmental issues, strengthening public health knowledge and skills within the Board of Health, the independence of the Board of Health. So again, you can see a wide range of issues that we not only heard from those 400 participants that we connected with, but also from the over almost 400 people that are on the line today. So thank you for that feedback. That's really helpful. We have two other questions we'd like to ask you. As you think about the things you heard today, what resonated most from what you heard? And then if you can say in one word or two, what describes your hopes for the future of public health, be that in Ontario or beyond? So you see a code of 7875-5078. Again, the code is in the chat box as well. So in terms of things that have resonated, people are mentioning the issue of better coordination, that things are aligned, that there's future planning to be ready for those changes that are inevitably coming, looking at issues of equity, improved access, aligned communication, the hope for the future of our planet, mental health supports across the board, greater capacity, consistent funding, a stronger public health system, making sure that staff recovery is supported, more funding, more resources, greater information sharing, increased emphasis on health promotion and healthy communities, rebuilding the trust that has been lost in some places between communities and public health, better coordination, emphasizing that public health has great value, health equity, recruitment of new public health professionals, access to mental health service, training, retention, recognizing that public health matters, greater capacity, reflection on the emergency preparedness for the future, effective multi-stakeholder communications, restoring public health to improve the health of all. So again, we're getting some terrific feedback here, and that's really helpful as we look at finalizing our position paper that we'll be using as we, as Ontario Public Health Association heads into the election and the outcome of that election. Now I'd ask if you could use the code 7875-5078 to talk in one word or two. What is your hopes for the future of public health? What are your hopes for the future of public health? So we're seeing lots of words coming to the fore, be they hopes for leadership, trust, collaboration, stability, funding, transparency, consistency, and with collaboration continuing to be something that is emphasized by so many of you, as well as issues of equity and trust, being valued. So as Casidhe mentioned, we'll be able to look at this cloud word, this word cloud afterwards, and see the kinds of feedback that people are providing in terms of their hopes for the future of public health. Thank you.
So just inviting Loretta back to join me to wrap up today's session.
Thank you, John. Well, I'd like to thank all of our speakers today. It's been an excellent opportunity for all of us to discuss key public health issues. And I'd like to thank all the staff at OPHA who were just wonderful to work with, and all of you in the audience. These are important discussions to have, and thank you for taking time out of your very busy day. We have posted here on this page a number of links for further information and contact information for both OPHA and OPHA. And with that, I will turn it over to John.
Just a big thank you to everyone who attended today, and also there's a thank you on the screen. We wanted to say on behalf of both organizations, the last 2 years plus have been difficult times in public health. The reports that you saw today could not have been, they're a reflection of, and participation couldn't have been done without the participation of our public health colleagues in the field. So we wanted to thank you for that, and wish you all the best for the future, safe and healthy future, and for the rest of Canadian Public Health Week.